classically speaking, so hyperkalemia is a real problem in patients with heart failure, with diabetes, with chronic kidney disease. And the problem here is that the patients who are at risk for hyperkalemia, which is heart failure, diabetes, and chronic kidney disease with low GFR, are exactly the patients who are relatively older, so your kidney function goes down with age, but more importantly are the ones that benefit, and we have these data from randomized controlled trial, who benefit from therapies that increases the risk of hyperkalemia. So it's a little bit ironic. So ACE inhibitors and angiotensin receptor blockers, mineralocorticoid receptor antagonists, all these therapies that improve outcomes for patients with heart failure, diabetes, and chronic kidney disease are exactly the patients that we cannot optimize the therapy because of the risk of hyperkalemia with these therapies. So hyperkalemia per se is relatively not that common. The problem right now is that what ends up happening is that somebody has hyperkalemia, and unless until you're on dialysis or really advanced renal disease, a lot of people don't just live in the hyperkalemic range. But what happens is that doctors, they don't just leave the patient with hyperkalemia, so they treat hyperkalemia acutely, but because we don't have any chronic therapies for hyperkalemia, though our reflex is to cut down the medications so that the risk of hyperkalemia goes down. So what is beneath the tip of the iceberg, what the iceberg in itself is, are people normokalemic but on the higher side who we are not optimizing their therapy because of the risk of hyperkalemia, because until now we did not have therapies that we can safely give long run. Classically speaking, we have good therapies for acute hyperkalemia therapy in the emergency room or whatever, and you can give patients, either reduce the risk of arrhythmias by giving calcium or glucose insulin or SPS, another name for that is K-oxalate, to reduce the risk of hyperkalemia. The problem is that in the long run, these things don't work. The SPS has a lot of side effects. It is not tolerated, but also there are some serious life-threatening side effects like colonic necrosis. So that's the problem. Long-term management, basically we have two options. So one is low potassium diet, which is very difficult to do because potassium is very prevalent in a lot of food we eat, but also look at it from the heart failure perspective or chronic kidney disease perspective, because also we are trying to manage fluid. We just talked. So one thing you ask the patient is to take low sodium diet, and they have coronary disease, so they need to take their low cholesterol diet, and they have diabetes, so they need to take low glucose diet, and now you're going to ask them to take low potassium diet. Like, what do you eat? It's very difficult. So it affects quality of life. The other thing, then alternative option that you have is to stop their medications. The problem is if you stop the medications, you artificially treat hyperkalemia, the potassium number goes down, but now you put the patients at higher risk for mortality, morbidity, because you've stopped the medication. So now we have two agents. There are two, Pitoramor and ZS9. Both of them have been studied in several studies that have been published in very well-reputed journals. Both of these bind potassium in the gastrointestinal tract. They are not absorbed systemically, and then they are excreted in feces. So you bind all the potassium in the GI tract, especially in the colon, and you just excrete them. We have data all the way up to 1 year that suggests that the side effect profile is very favorable. There are no life-threatening side effects, and it opens up the door not only to treat hyperkalemia chronically, but actually be able to potentially optimize medications for these drugs by giving these things to prevent hyperkalemia. Although we have trials for treatment of hyperkalemia, I do want to highlight that we don't have data for prevention and optimization of therapy, at least not as much as one trial that looked at it. But the option is there, and I think more studies will be done. Pitoramor was approved by the FDA a few months back, and ZS9 will be reviewed by the FDA soon. So, all the patients who are at risk for hyperkalemia, who have had documented hyperkalemia maybe even once, all of these patients will be eligible. The question is who will step up and do the prevention trial first. But for treatment, if you have hyperkalemia, pretty much all of the patients can take this. I mean, I would say that in the beginning, probably the number one group of doctors that will use that will be nephrologists because of the chronic kidney disease and hyperkalemia risk. But then over time, I think more and more general practitioners, cardiologists, endocrinologists will use it. But because the treatment of hyperkalemia is primarily an issue with nephrologists, they will be the early adopters. But when you start talking about prevention, we need a few more studies, and as those studies for prevention comes out, it clearly will be used more widely by a wider range of doctors.